she's doing a wonderful job in the biggest pediatric hospital in my country, Garrahan Hospital, about migraine and in the childhood. So, Patricia, is the video ready?
Hello, welcome. Thank you very much for this kind invitation to talk in this meeting. I am Patricia Sommerfleck. I am otorhinolaryngology in a tertiary care center of Buenos Aires, Argentina. It is a pediatric hospital, Professor Garrahan. We attend only pediatric patients from birth to 16 or sometimes 18 years old. Our topic today is vertigo in pediatric patients. The most important tool that we use for diagnostic of dizziness is the interrogatory, the medical interview. We always say that the interrogatory is the 80% of diagnosis and the complementary exams only confirm our suspicion. But with pediatric patients, this is the first obstacle that we have. Sometimes it's very difficult for the children to tell us the symptoms, and this step demands a lot of patience. After a few years working with children, I could say that the secret is to learn how they express their symptoms. 2 weeks ago, I asked to a 3-year-old boy how is his vertigo crisis, and he answered me, So I don't know any more words. It was vertigo. So we have to listen to children with a lot of time and listen to parents too. The parents who have not actually experienced the episode may distort it according to their interpretations and concerns. They feel worried and very afraid for the situation. The other point is that a lot of time all the family pass for a huge number of professional and different physicians and a lot of different tests, so they are tired and worried too. The first idea that we have to know is that children is not medial. It's not the same. The prevalence of different pathologies are not the same in children than in adults. Which are the most frequent symptoms for our medical consultation? It is headache and vertigo dizziness. I want to make a clarification that I work in a otorhinolaryngology department, so the children who came for the medical consultation is not the same that in general pediatric consultation or neurology or other specialties. But we work in an interdisciplinary team and we always carry on interconsultation. For this presentation, I will show you this study. We include in the study 512 patients between 1 to 18 years old. 263 are girls and 249 are boys. And the median age was 9 years. Now we will see the percentage of symptoms in the medical consultation. Headache and balance disorders are the 35.5%, then vertigo almost 26%, and then we have paroxysmal episode, ataxia, dizziness, gait disorder, motion sickness, syncope, hear loss, and others. If we add the first headache and balance disorders and vertigo, we have here more than 60%. That is a lot. It must be clear that headache and vertigo is not the same than vestibular migraine. For vestibular migraine are specific diagnostic criteria. The Committee for Classification of Vestibular Disorder of the Varani Society and the Migraine Classification Subcommittee of International Head Society define those criteria to categorize headache within vestibular migraine. And we divide here vestibular migraine and probable vestibular migraine. To summarize, for the diagnostic, we have to consider recurrent vestibular symptoms, positive history of migraine, temporal association between vestibular symptoms and migraine symptoms, and exclusion of other causes for vestibular symptoms. For the diagnosis, the medical record, the anamnesis, is very, very important, and carefully otoneurological and physical examination is important too. Evaluate the diagnostic criteria in detail. We can find in the crisis or patient could tell us about blocked ear or hearing loss during the crisis. With the BNC, we could say we could sing central nystagmus, and in this population, it's very important to determine which cases require a different treatment. The headache classification, there we look for pediatric consideration, but they are not different between the adults and children classification. They classify the different type of headache indistinctly with the same criteria regardless of age range, although they have some specific observation for the pediatric age. So the headache classification is very long. It has more than 13 different items with specific pathologies, but I took only the section we need for this study. I want to be clear that it's not the complete classification, only that we need, or the most frequent in our study. So we divide in primary headache and secondary headache. In primary headache, we have migraine without aura, migraine with aura, tension headache, other headaches. In the appendix, we can find vestibular migraine or headache for psychiatric or emotional disorder. And in the secondary headache, we can find tumors, infection, trauma, neighboring structure disorder, sleep apnea, hypopnea, refraction disturbance. Secondary headaches are the ones that should take our attention and always be alert, because it's very important. So we have those red flags. The progressive character in intensity and frequency, the headache who wake up the child or start early in the morning, or is exacerbated by coughing or sneezing, when it is in recent onset with severe headache, when the child has neurological signs like papilledema or abnormalities of the cranial nerves, motor deficit, cognitive deficits, if the child has secondary risk factors like blood dyscrasia, systemic disease, immunosuppression, tumors, etc. It's not the same a child of 2 years old or a child of 12 years old. So we take this simple division proposed by the World Health Organization, who divide them in 3 groups. Under 5 years old, the first childhood, between 6 to 11 years old, the second childhood, and the third group between 12 to 18 years old, teenagers. Now we will analyze our sample only the patients who have balance disorders and headache according to this classification for the World Health Organization. So we have under 5 years old, 46 patients. They are 24 girls and 22 boys. All of them have benign paroxysmal vertigo of childhood. In the second group, 6 to 11 years old, we have 109 patients, 61 girls and 48 boys. And the third group, 73 patients, 48 are girls and 25 boys. The prevalence of headache in pediatric population is very important. According to different studies, it can be between 6 to 82%. But if we talk specifically about migraine, children 3% and teenagers 20%. Under 5 years old, they have this this type of presentation. Recurrent gastrointestinal disorders, cyclic vomiting syndrome, abdominal migraine, benign paroxysmal vertigo of childhood, benign paroxysmal torticollis, paroxysmal infant colic. All of them are manifestation or equivalent of migraine. Children under 5 years old, we have in total 54 that consult for paroxysmal episode, vertigo, and headaches. 46 of them have the diagnostic of benign paroxysmal vertigo of childhood. That is corresponds to almost 9% of the total sample. From the second group, we have 109 patients between 6 to 11 years old who reported vestibular symptoms and headache. Here we have 47 patients, that is the 43%, with primary headaches, like we said before. Then 45 patients who met the diagnostic criteria of vestibular migraine, defined and probable vestibular migraine, and a group of 17 who had another diagnosis. For study those 45 children who met diagnostic for vestibular migraine, we have this graphic, and 23, that is the 51%, have defined vestibular migraine, 18 have probable vestibular migraine, and 4 patients after follow-up, they pass from probable vestibular migraine to defined vestibular migraine. What happened with the patients between 12 to 18 years old? We have 73 patients. Here is the graphic. 32, that is the 44%, have different primary headaches. Then 27, that is the 37%, met criteria of vestibular migraine, defined and probable vestibular migraine, and 14, that is here, they have others pathologies. In the other graphic, we have for these 27 patients, the second graphic, and we have 18 patients with defined vestibular migraine, 8, that is the 29% probable vestibular migraine, and 1 patient in the progression after follow-up passed from probable vestibular migraine to defined vestibular migraine. For a summary of all of these numbers, we have 512 patients were evaluated in 66 months, 182, that is the 35.5%, consulted for headache and balance disorders. 46 of them, that is the 9%, have benign paroxysmal vertigo of childhood, which is a manifestation of migraine. They are not included in the group before. Then 72, that is the 14%, is a group composed of probable and defined vestibular migraine, and the progression from probable to defined vestibular migraine too. And then 79 patients of the total sample had other primary headaches. In conclusion, the vestibular migraine can be difficult to apply those criteria in the pediatric population. The follow-up of the patient and the evolution could generate some changes in the classification of the headache, so we have to be alert of this situation. And not all cases require the same treatment. It's not the same for all the children. Thank you very much for this invitation.
Thank you, Patricia, for this wonderful talk. let's see. Are you alive?
Yes,
I mean,
I am
not
here.
live. Sorry, I need my cup of coffee today. Hi, how are you? Sorry for. I saw that in the program you were in the same line below Sudhir, so I totally missed it. I'm so sorry. So
No problem.
I'm looking for questions, and then I want to tell you something very interesting about what your patient reported. So I don't see any questions from the audience, but I must say that your patient who reported how they perceived the vertigo, that's so interesting, because we were trying to design, about a decade ago, we were trying to come up with some way of quantifying the perceptual velocity storage. And one of the ways, as Diego and Barry and Adolfo and a lot of our colleagues did, was they spin the wheel, right? Like they spin a little wheel, how they feel the spinning, and we came up with that. But then the other thing was they're sitting in the chair and they're supposed to just verbalize as they feel that they are spinning, right? And then we take that, and Zuma and I are trying to put together a project. We take that volume and then we see how the time constant fits. So when they said, it was so, it's so interesting. It's so natural way of people reporting how they perceive, which is very interesting. And even 3-year-old knows how to do that.
Perhaps for others, they make a lot, they talk a lot, and we have to listen them and try to understand what happened with them. But with children, we have to make it simple.
Yes, I agree.
Take a lot of time. That is true, because we have to listen to the child, listen to the parents too, and we have to make a good relation with the child. Like playing with them for them to tell us what happened. It's not so easy, but not all children tell so easy the symptoms, but they are some funny kids.
Yeah, but learning that as a lesson, maybe we can import that idea of reporting perception as instead of we are seeing nystagmus in adults, because as day by day we are seeing more and more ways of reporting perception, and clearly scientifically this was one of the ways people have used, like using the verbal tone and then quantifying verbal tone to study the human perception of spinning. So maybe we can use that in even adults to kind of like quantify like how much they have. It's impossible otherwise to quantify.
Yeah.
It's pretty interesting. Thank you very much for doing this. Any other questions from the panels? Let me just check one last time. I don't see any from the audience, so. Great, thank you so much. So now we are with Sergio. Of course, I'm going to repeat the same announcement again. Sergio Carmona does not need any introduction. He is the head of the Department of Neuro-Otology in Institute of Neuroscience at Buenos Aires. He is the president of FINO and a very well-known clinician and scientist in South America, North America, and through the world. With that, he's going to